Well, hello, everybody. Thanks so much for coming. We're pleased to be a part of Open Data Week. My name is Matthew Montesano. I work for the New York City Department of Health and Mental Hygiene. My job is to make public health data easier to access, understand, and use. I'm joined by my colleague, Corinne Thompson. Corinne, could you please introduce yourself?
Hi, everybody. My name is Corinne Thompson. I'm an epidemiologist at the health department, and I am part of what's called the Epi-Data team here in the surveillance and epidemiology branch. And my team is responsible for all of the public-facing, well, most of the public-facing data that hopefully you're familiar with. Thanks.
Yes. Thank you, Corinne. So we're here to talk about challenges and opportunities to communicate data in a crisis such as the one that we've faced over the past week. I'll also note that Corinne and I represent a large team of people working very hard to gather, process, clean, analyze, and release this data. The work that we're going to be talking about here is by no means done by just the two of us. We'll offer you a overview of what we've got going on today. So we're going to talk about why it's so important to communicate data in a health crisis. And we're going to give an overview of health surveillance data and the processes for collecting and publishing these data. We're going to talk about how this happens normally and how it's happened for COVID. And why the situation with COVID-19 has been so unique and raised really unique challenges. We are going to give an overview of what the Department of Health and Mental Hygiene has done to make COVID-19 data easier to access, understand, and use. Those are our data communication goals there. Show what we did and why we did it. We're going to get into some of the unique challenges posed by health data generally. And then we're going to do some wrap up, get up on a soapbox a little bit, take some questions if we have time. We plan to wrap up at 2 p.m. All right. So to get started, communicating data in a health crisis. Has anybody in the audience looked up any health data over the past year? Maybe obsessively? This was an in-person conversation. Just a little. Yeah. If this was, in person, I'd, ask people to raise their hands and we would go through that whole rigmarole. Needless to say, a lot of people have been focused on health data over the past year. It's early March, it's mid-March, so we're in this sort of auspicious anniversary of lockdowns coming up. And if you were looking up data on COVID-19 in New York City early on in the pandemic, around this time last year, you might have seen something like this in March 2020. This was pretty bare bones. This was data communication at a time when there weren't many cases. And as you may recall, a week or so after this, we were well and truly into a dangerous period of an epidemic. Exponential growth. And at this point, the department's data communication grew, and a PDF that had been used for internal communication and situational awareness became, for a short period of time, the de facto external data communication platform. But I think it probably goes without saying to a lot of people that when people are looking for data, they're not usually looking to download a PDF. When people are looking for data, they're not even looking for a number often. They're looking for information. They're looking for how that number compares to another one, how that number has changed over time, or they're looking for something bigger. They're looking for a sign that the Department of Health is working to protect them. They're looking for reassurance because they're afraid, and this is an outlet for that. I know that in March of last year, I certainly was afraid. And at this time last year, the government, public health infrastructure, the country, the world, needed everybody to take some action, to stay home, to take kids out of school, close businesses, protect each other. And that means that we needed people to understand risk and trust that we were working to protect them. And that winds up being a big issue in data communications. In a crisis or unknown situation, people have questions. And if they know that you have answers and you don't share those answers, if you don't share the information that they know you have, they're going to wonder what you're hiding and why. So at a time when there were these big questions afoot, how many cases are there in the city? How fast are case counts rising? Where are they happening? How at risk am I or is my family? What are we in for? At this time, it was really important to give clear answers. And data transparency can be a vital, vital tool for this. So giving answers means getting data out in a useful way. But if I'm honest, a lot of government agencies are not well equipped to move fast, be flexible, or deploy strong digital products. Government agencies usually move slower. They're organizations that are designed to be durable and deliberate. But in a pandemic, it's important to use fast. And in this case, when it comes to mass communication, it's important to use technology well. Welcome to Open Data Week. It's important to use technology well. I'm sure I'm preaching to the choir here. As the author of this tweet points out, using technology well doesn't necessarily mean using particularly advanced technology, just using the right technology for the job. This author points out that a huge way to improve data communications is just to publish CSVs, publish data in a CSV file. This is the right technology for the job. But again, many government agencies don't have robust experience or expertise deploying fast, flexible digital services or data communication products. Some don't have structure to do it. Some don't understand that it's important. Sometimes there's not the political will. There can be a view sometimes that more information is risky. These challenges exist in many government agencies, many different entities. When it came to COVID-19, when it comes to COVID-19 in general, these challenges take on another dimension. COVID-19 data are a little bit unique among what we call health surveillance data in many ways. And here to offer a little bit more information and context about this, I would like to turn things over to Corinne to provide some background on how the health surveillance data process, data collection and reporting usually work.
Okay, thank you, Matthew. So yeah, as mentioned, how things normally work is I work typically in the Bureau of Communicable Disease, and we are responsible for about 75 different infectious diseases across the city, and these are legally mandated through the New York City Health Code to be reported to us when they're detected. To give us the powers to try to protect the health of the public when there's a known and identified risk. So the typical way that we get this information is through what are called electronic laboratory reports. So legally, when a doctor's office or a laboratory diagnoses one of a number of diseases, including COVID, will be sent an electronic laboratory report. And then next slide, please. The typical processes here. So if you start to feel sick on a Monday, for example, you'll go to seek care at a doctor's office or hospital on a Tuesday or a Wednesday. They'll take a specimen, in the case of COVID, send it to a laboratory by Thursday or so. And then when that laboratory finishes the test result, they'll send it to the New York State Department of Health. And the information that's included on that lab report form that goes to New York State is very bare bones and very basic. So it'll have patient name, date of birth, residence, and the lab result. And that is the most of the information that is sent. So we don't often have a lot of information, including, for example, race and ethnicity off the back of those lab reports. And then New York State will send to us at New York City anybody that's known to be a resident of New York City. Next slide, please. So, right. Typically, what happens is we will when we receive information from New York State, we will understand if there's any actionable public health response to be taken. But to do that, we need to get our data in order. So what needs to happen is we have to clean the data, because it can be very, very messy. We have to do what's called deduplication. So in the case of COVID, there at the beginning, you were getting a swab in each nostril, for example, and those would often come in twice. And so one person would have two lab results. We also have things like twins, for example, will have same date of birth and same address, but different names, but very similar, but different names. We also have instances of something like a father and a son, so a senior and a junior, have the same name in the same house. So there is some manual human review that has to go into this. And so there's a kind of a lot of data scrubbing that has to happen. And then next slide. Then we kind of assembled, after we identified that there was a problem a year ago, we sat down with a big group of people to try to understand, okay, what are the major questions that we want to ask of this data, and how do we want to report out routinely? Because we recognize that many people are going to want to know that information, including the public, but also, internal stakeholders as well. Next slide. So what we ended up doing, and what we're still doing now, is we have a huge amount of routine reporting that happens every day. So the data come in, we clean it, and then we report out online and to our GitHub page. We also report out to internal decision makers at the health department and also to City Hall. And also try to make sure that elected officials and community members feel informed through our data on the webpage that Matthew will talk more about. This was a unique challenge for a number of reasons. Number one, because COVID obviously was a new disease, and so it was very difficult to know how to communicate a new disease in real time. Also, just to note, we normally publish data about once a year for most of our diseases. So we have a repository known as EpiQuery, where you can go and find tons of disease data that goes back for a number of years. But we just actually published 2020 data, I think, maybe 2019 data actually, on our webpage. So it takes us a long time typically to review and clean and make sure all of our data is accurate before we put it up. So this is a big departure. The idea that we're going to be reporting out real-time data was for a huge amount of time was a big departure from normality for us. Next slide, please. There were a ton of different challenges, as you can imagine. So people don't like it when data are messy or when data change. And as you know, COVID has been nothing but if not changing from the beginning. Communicating the inherent limitations of surveillance data has been a learning experience for everyone. I think the kind of baseline literacy of epidemiology as a field of science has definitely improved among the public and elected officials and others over the last 12 months. But at the beginning, it's very difficult to communicate what in epidemiology is very normal, where the data are very noisy and everything's gray. And people typically wanted to have black and white responses to a lot of our data. And we try to get away from the idea that we did something wrong when data were changing or definitions were changing, because as Matthew mentioned, we need the public and the media to trust us. So we have to explain very technical details in a clear way all the time to make sure that people trust that we're trying our best and that they can trust the data that we're putting out. And I think I'm going to hand it back to Matthew.
Yeah, thank you so much, Corinne. And I want to just, take a moment and stress something that you said about how usually we publish data once a year, and those processes of collecting data and then analyzing it and then making decisions about the proper way to analyze it and publish it and then publishing it. Those are steps that sort of follow each other one at a time. And for COVID, it's just been a constant process. There's constant data collection, there's constant analysis, and constantly updating strategies for analysis and techniques for analysis, and then constant reporting as we update the data every day. So it's a really very, very different mode from what the department is used to doing. So given the challenges that Corinne mentioned, the agency had these goals for COVID-19 data communication. The primary goal, of course, is to influence policy and save lives. The Department of Health's mission is to protect and promote the health of all New Yorkers. And in order to do that, we needed to clearly deliver our expert understanding about the data. In epidemiology, we talk about person, place, and time being the basic building blocks, but also what data are reliable, what this means for New Yorkers. That's a crucial component. And we needed to provide that information to a lot of different people. The pandemic has required a population-wide response. We needed everybody to be able to act. And that meant that we needed to prepare this information as a tool for many different people to access and use. So here's what we did to work toward those goals. For starters, we began publishing a website with data visualizations. This is what it looks like now, or at least as of when I screenshotted things to prep these slides. It started out a little bit simpler. We were strategically designing visualizations, not just to report values, but to communicate for understanding, right? So we were synthesizing findings from fields like evaluation, behavioral design, data visualization design, and health communications, and bringing in some lessons around, reducing chart junk, directly labeling data, information chunking, interactivity. There's some research that shows that modest levels of interactivity actually increase trust in data and its findings, and specifically increase engagement with health information. So that's something that we wanted to bring in so that people found this easy to use and easy to understand. We were trying to build visualizations that would provide data in a format that answered people's questions the right way, that provided the right comparison or finding that we wanted people to get, right? That was us trying to offer our understanding and make sure that people got it. I think this should be an overwhelming concern for data visualization, especially in this communication-focused context. And now, personally, I hate dashboards. We didn't want to build a technical-looking dashboard. We wanted to build something designed for lay data users that let them navigate through familiar web interfaces in which we could intersperse interpretation and explanation, especially around these new metrics. I noted that early on when data around percent positivity were released, there was a lot of confusion about that. And some people understood it to mean the percent of all people who were testing positive for COVID, but it's the percent of people tested that tested positive. So, particularly early on, using techniques to intersperse explanation is really valuable. And I know that we're speaking to an Open Data Week audience, and I know that probably most of you in the audience are fairly technically inclined, but I'd also say that most people are not like you. Most people don't want, need, or use access to raw data. I think that most people need a clear, most direct, easy to use statement about what's happening. So we tried to design visualizations in this first layer of data access to provide that. We wanted to build something that was accessible to people who use keyboards or screen readers to navigate the web. And we wanted to provide it in a few different contexts. This is a tool that was released a little bit more recently that puts the data in a neighborhood-focused context and report case counts and rates and death counts and rates and some other data in another easy to use way by putting it in sentence context. So overall, these concerns of ours, oops, going too fast. These concerns of ours were clarity, accessibility, plain language, and straightforward designs and explanations. But we can go back to this comment, which really anchors, I think, some of the themes of trust and technology that I spoke about earlier. Obviously, I think that offering access to the data, not just to the understanding, the interpretation that I just talked about, but access to some of the underlying data was a huge component of reliability, particularly early on when there was a lot of confusion. So offering, taking Max C. Roser's advice and offering data as CSV files became a part of our strategy early on. As Corinne mentioned, part of the strategy that we were planning for was the knowledge that data would change, that they are dynamic, that analyses would update, that information that we were getting from the state would change, that case counts would sort of rise and fall in different ways as different processes were refined. So we knew that throughout this process, we would make necessary changes to our calculations or processes that people would notice and that could generate confusion. And when data change, as Corinne said, nobody likes when data changes. It can look like manipulation or something like it. It can look like something confusing or untrustworthy when something raises more questions than it answers. So in order to provide access to not only the data, but our processes and our rationale, we offered data access via GitHub and published our CSVs there. This is, for us, a pretty reliable one-stop shop. It let us make really easy daily updates. It let us, it did all the work in tracking all of the commit history so people can easily go back and get old versions of the data. It let us post extensive documentation without interfering with the usability of our web pages. And I know that made the epidemiologists happy, since they want nothing more than to completely cover a visualization with footnotes. And it made our data viz people happy because we got to prevent that from happening. It also made our comms and press people happy because they could point to the documentation when questions came in. So overall, the system let people grab these data, pull them into their own systems, and work with them in a much easier way than other common forms. Recently, Mike Bostock, who is one of the developers of D3.js, which is a powerful data visualization library, released his reflections on 10 years of writing this software. And he wrote about support as a powerful means of research, that providing users with support is an important way to learn where they struggle, what they struggle with, and how you can improve your product or service. So we used the GitHub repository as a means to do this, using the issues feature as a way to answer questions, clarify issues, understand what issues people were having with the data, and figure out how we could provide a better sense of understanding of the data so that they can use it well. Government agencies don't often get the opportunity to talk openly with users in this way, or government workers don't often get the opportunity to do so. But doing this took a potential risk, the idea that the agency could be criticized for data that changes, as we're reporting results from a messy system that's changing all the time. And it turns that into risk mitigation, doing it all above board, documented, supported, so that people see when it changes, get explanations about why, and they can understand and use the data properly. An example from very early on is the fact that we were using something called the date of event for data like cases. And that means that if someone is diagnosed with COVID, the date that applies for their case is the date of their test result, their diagnosis. So that means that our data update today might include updating old values from prior days. And there was some confusion around this, right? As early on, people were saying, yesterday it said that there were this number of cases on this day, and now that number has changed. Why? And it's because we're backdating based on when things happened, not just adding numbers based on when we learned them. So I'm not going to pretend that this is the most sophisticated strategy or even the ideal one. But to sum up, I think this is something that is really powerful in a public agency context, because this strategy is something that we could implement overnight, right? It used free open source software, free accounts, common tools, easy to pick up functionality. And these approaches directly gave us the ability to meet our communication and health promotion goals, considering the challenges that this circumstance raised. Now, we've talked about some of the unique challenges of communicating COVID-19 data. And our goal was to be as transparent as possible so that the changes, the variation, the reliability, all that was clear to people who were digging in and using these data. But there are other challenges too, and these came when we would field requests for things like record level data. And that gets at a certain tension with open data in a health context, I think. I like this tweet. It really gets at the heart of things. What we were providing wasn't open data, it was open statistics. So as I mentioned, we fielded this request, why don't we release record level data to let people do their own in-depth analyses? There are a few answers to that. I'd like to turn things back over to Corinne, who can talk about things like privacy and the added value of epidemiology.
Thank you, Matthew. Yeah. So just to kind of give some context, it's very, very rare to make any sort of temporally disaggregated data available from a health perspective in near real time. And also just to note that we have really strict privacy constraints on us as an agency, and it's surprisingly easy to identify people from de-identified data. So typically we have rules like rules of thumb that guide data protection. So for example, if a cell count is smaller than 5, we typically will censor that information. We typically try, if a population denominator is very small, for example, we try to make sure that we don't also put out small numerator data just because that can be identifiable. And we work with these data on the expectation from the public of confidentiality. And as mentioned, there are legal protections to most of these data. So it means that we don't typically, it means that we release aggregated data. And for, a disease like COVID, where there's just so much data, we think that aggregated data over time is definitely better than no data. And then secondly, as Matthew mentioned, the role of epidemiology, there's quite a value add of epidemiology, if I don't have to say so myself, just because we as epidemiologists really understand the health data and not only the health data, but the properties of infectious diseases. And this subject matter expertise is really critical to making sense of the data because it's quite noisy and it can be very overwhelming to try to understand patterns through data if you don't understand it. We are, as mentioned before, we're using established standards for cleaning and analyzing this data, but we're also trying to understand the best questions we can ask of the data, determining what the data reliably answers, or which questions the data can reliably answer on the knowledge of the entire data delivery system. We're well aware as epidemiologists of the gaps and the kind of pitfalls in our data that may not be obvious to people external to the system. So we try to take the noisy, messy data that we see on the back end and essentially help translate that a little bit to the larger public and people like yourselves who are more familiar with data. And I think now I'm going to turn it over to Matthew again.
Yeah, thank you so much, Corinne. The last item that I want to add on to your point again goes back to the mission of the Department of Health to protect and promote the health of New Yorkers. Mass health events are really sensitive, and in this environment, information plays a really powerful role. And given that, I think it was really important to speak with a clear voice, to use data to describe what we know about how COVID was affecting the city. We've used these sort of techniques and methods from the open data movement, but we've had to filter them through these important health concerns and the knowledge about how information affects behavior and health. So this, I think, is moving beyond just data publishing and towards this sort of soup to nuts work of communicating data, delivering it so that it can influence policy, change behavior, and ultimately, we hope, save lives. Or in other words, we'll let the data speak for itself when it cleans itself, but that's mostly a joke that I just couldn't pass up including in here. So we're actually moving through this a little bit faster than I expected. It's about 1:30, which means that we'll have more time to perhaps answer some questions in chat. But as we're wrapping up, I want to offer a brief look at the results of our work, and that's this. The pandemic resulted in the Department of Health's website getting web traffic. Again, people looking for answers. That was 10 times higher than prior to the pandemic, right? A whole order of magnitude. And when we launched the data pages, they were over 40% of the department's page views and visits, which I think really underscores the role that data can play in an emergency. And again, I want to reinforce the point that I made earlier on that often when people are looking for data, they're not necessarily looking for a number, but data can be this important avenue by which health information can be offered, by which behavior can be changed, that people's concerns can be addressed. We also think that that level of interest is a sign that that we built a persistently useful tool, which makes us feel great. But we also think that the goal of ensuring that the data were influential and useful to other people, we really believe that was met. When we would release data, we would see graphical features in the Times, local newsrooms were making data explorers, academics and others were making their own dashboards, dozens of academic papers that helped articulate disparities around testing access, around case hospitalization and death distribution were published. News articles were embedding our charts. We saw our epi curves on the Rachel Maddow show once. We think that this is a sign that we made data easier to use, and that helped increase its reach and its influence. I don't want to overstate that point because I think clearly everywhere has seen an explosion of interest in COVID data. New York City is not alone in that. But thinking, beyond COVID, I think that it's important to consider a more significant openness around data as being a potential tool to reach more people with health information. We did so by sticking to fundamentals around public health in communication. Who's your audience? What do they want and need? What do you want or need them to know or do? And how do you format and deliver your information so that it can happen? For government agencies, absorbing some tools, tactics, and values from the open data movement offers room to make some big improvements in that low-hanging fruit way that someone on Twitter said. It offers an opportunity to mitigate risk by being more open and transparent, and offers an opportunity to leverage our data, get it into more people's hands, understood correctly, and let the data be used to have a bigger impact. The data landscape during the pandemic has been, as we've said, volatile and constantly changing. And I think it's been so important for government agencies to provide access to its knowledge to the public. There's been no time when this has been more important. So I think that this is the soapbox part. It's important to look past traditional government ways of communicating data and look toward more open, transparent, and flexible strategies. We think that this has saved lives, and we hope that it can provide some inspiration and model to other public agencies to pursue and expand upon. And that's my soapbox. I'm noticing some things coming in the chat, and I'd love to answer some of these items. Let's see. I'm noticing items in the chat. Does anybody want to unmute themselves and verbally offer their questions? If not, that's fine too.
I would. Hi, this is Noel Hidalgo from BetaNYC. Thank you for presenting here at Open Data Week, and thank you for your unbelievable year of service. Just some technical questions, and this is something that we were advocating on prior to the data actually being released, was getting the data on the Open Data portal. And while I do see value in the data being released on GitHub for all of the reasons that you mentioned, I'd love to know, what were some of the roadblocks or what were some of the barriers to initially releasing the tabular data on the Open Data portal, and like in the future. What are some of the wishes that you would have in the Open Data portal, so that way, the city's data could all be sitting in the same bucket instead of having data on GitHub and other data being on the Open Data portal? Yeah,
that's a really great question, and I absolutely see the value and the importance of that centralized approach. I'm not sure I can speak to every aspect of that, but I will say that when we began this work, we were looking for something that, like I said, that we could do overnight. And we didn't have an opportunity to review sort of all of the possible approaches or all of the implications of all of the approaches before picking one. We had to go with what do we know how to do right now? And that was our approach. Another thing is that while we have worked to expand and iterate and improve what we've done, we haven't really had the luxury to revisit some of our initial assumptions, right? The tools that we chose a year ago let us get this work done so that we could move on to other work. The team that we're working with, everyone is doing 2 or 3 jobs right now. And so, I think one of the reasons that I reinforce this as something that's possible for public agencies is because it it lets people sort of check something off and move on to the next thing in a crisis when resources are stretched thin.
Yeah, and I can comment. I've been involved in trying to get more of our data from GitHub onto Open Data. And at the beginning, there were a lot of conversations about how to supply the data to Open Data, to how to do a draw. It's more just the nuts and bolts of like, how do we get CSVs to Open Data? And the Open Data structure is the appending structure. Every day you add a new, the entire data set, as opposed to the GitHub, which is more not for computers, but more for human consumption. So eventually we just settled on Open Data pulling information from GitHub directly, but I'm sure that that's probably not the ideal situation. It's probably better to have, us send directly the data right to Open Data. And then I can also say the documentation is another stumbling block, just because there's like very specific Open Data requirements for documentation that are similar, but slightly different to the way we put it onto GitHub. So it's mostly just a lack of time, honestly, from the small team here that's been working on all of it. So we are slowly working on getting all of the documentation in the right format for Open Data. So we're trying to we've just done the antibody data. We're focusing now on data sets that probably won't change, because the other element to this is that things are changing. So what we put up changes, and the definitions of what we put up change. And so we're trying to pick stable things that probably won't change to be the first tranche of data that we put on Open Data. Although I recognize it's been a full year, we're still working on it. So it's mostly a matter of time, unfortunately. But I think it would be great to have everything on Open Data, because it's, that's the right thing to do.
There's also a comment from someone else at Open Data who points out that, the GitHub release was nimble and immediate, and that the Open Data process, even when rushed, is not as fast, and that's okay. And I think, this goes back to like different tools for different needs, both being really important, and where we were at a year ago had the sense of immediacy to us. There's also a question, are you collaborating with other cities or states? How do you see national data availability? Are there any other good practices that you liked in other cities?
Can we do that?
Yeah, definitely. Early on, we were definitely looking at what a lot of other places were doing. Gosh, there was a county in Washington that had one of the good early COVID trackers. Corinne, do you remember what county
Yeah, it was
that
King
was?
County. Yeah, Seattle, King County. Yeah, they're very good.
Yeah, so they started, I think they really set some of the early tone of, this is happening, we've got numbers, people want these numbers. How do we give this information to people, and how do we answer their questions? I didn't particularly care for like all of the ways that they did that. I've also noted that some other cities and states have been doing, a lot more. Occasionally, there's sort of more interactivity. We've seen some APIs out there, but I will confess to really having my head pretty buried in New York City's data for the most part over the last year.
Yeah, and I'll just comment from a 30,000-foot viewpoint. Public health has not been on the top of anyone's funding agenda for many, many decades, and that was evident in many ways, when COVID broke. But one of the ways, we still fax things to CDC, like as a routine practice of transmission of data. So we, as a field, were wholly unprepared, I think, to deal with the onslaught of what is COVID. And I think some of the jurisdictions that are lucky enough to have people like Matthew who understand data communication and have the tools and the experience to help project that information, not every jurisdiction will have this skill set. And CDC, also not particularly well funded in this area. To their credit, they've made huge strides more recently, but at the very beginning, it was alarming to see the main repositories be private academic. Johns Hopkins still has a huge data repository, but frankly, New York Times and Washington Post are probably some of the main go-to sites for the majority of the public, and that just speaks to the kind of, I guess, the evolution of data visualization as a kind of integral part of people's lives now. But yeah, we communicate some. I don't think we actually communicated so heavily with other jurisdictions about how to do it at the very beginning, because we were just scrambling to put anything up. But there's still tons of questions that don't really have clear answers. How do we calculate percent positivity, for example? Every jurisdiction will do it slightly differently. They had a lot of discussion back and forth with New York State about how they do it and how their numbers are different than our numbers for our own boroughs, because there is no clear guidance, because these decisions are not easy to make. So I think you're seeing the same thing with vaccine data. I mean, I think the vaccine dashboards across the country are also going to be slightly different. And it's just a bit of the way that our country is set up, where we don't really have a nationalized system. So everybody, but it's been a great laboratory. I think there's been a lot of kind of sharing of ideas and ways to communicate data.
I think one of the interesting ramifications of that is, there have been, Corinne mentioned the New York Times, the Washington Post, and Johns Hopkins, right? There are all these other third-party aggregators, and what they wind up doing, they wind up collecting so much information and being able to provide a certain level of cross comparability to it, but they also sort of remove a layer of detail in trying to in trying to standardize data from all these different cities and states and countries that are gathering, analyzing, and reporting their data not in standardized ways. I think this also leads into a question in the chat. Has DOHMH automated any of the data scrubbing? And the answer is yes. There's a sort of gigantic mix of both automation and manual work that goes into any one record making its way, first of all, into our machines, through all of our systems, and then part of the aggregated statistics that get released. Corinne, do you want to offer a little bit of a peek behind the curtain?
Yeah, I'm not, that's not necessarily my area of expertise, but I'll just say we have lots of full-time people whose job is primarily data cleaning. So the examples that I gave about twins and fathers and sons, that's kind of an example where humans are sometimes necessary because a computer will look at that and on matching algorithms and things, assume that they're the same person. So we have a ton, yes, lots and lots and lots of automated data collection. The number of records that we have coming into our system daily, the vast majority a human will never touch. It's mostly automated.
Thanks. There's also a question. I'm sort of bouncing around in the chat. If anyone feels like they're being overlooked, please feel free to ask your question again. I'm sort of trying to follow themes here. Noel asked again, with race, ethnicity being such an important factor in this pandemic, how have processes change so that it is collected sooner? Great question. Corinne, can you field that one?
Yes. So there are kind of three, this is a really common question, and a lot of people have been working on it. So there are kind of three main areas of answer to this question. So the first is when you ask someone, if you're a doctor's office, the race and ethnicity, often people will not want to tell you. So that's just as a general rule, you're always going to have like a do not decline. That being said, we definitely have a lot of missingness that shouldn't be there. And so we can certainly, there are hopefully avenues of improving race and ethnicity. The second kind of level is, as I mentioned, the data transmission from the lab. So all of the patient information, for the most part, that we get comes from the electronic laboratory report. And so that is based on whatever information the laboratory is reporting up to New York State. So if you go to a doctor's office and you check off your race and ethnicity on a form in the doctor's office, that information may not necessarily be transmitted to the lab. And then even if it is transmitted to the lab may not transmit that information up to the state. And the issues with that revolve around messaging, so how the data are classified. Each clinic and each doctor's office may collect race and ethnicity slightly differently. So a data transmission format, it's not always standardized, and so that just requires, frankly, funding and probably more guidance from us and the state and others. And then the third kind of realm of issue with race and ethnicity relates to denominator data. So as epidemiologists, we don't like to report out counts, even though the public like them. We like to report out rates because it makes it much easier to compare between populations like the Bronx and Brooklyn, or compare over time. So instead of just saying, well, the Bronx had 17 cases and Staten Island had 27 cases, we'd like to say per 100,000 residents, because it enables you to see more readily where there's a potential problem. And so because census data is derived from the federal government, the Office of Management and Budget of the federal government, there's, I think, 5 major race and ethnicity categories from the federal government that the census collects and will then break down by age, and by gender, which is really important for the work that we do. So in order to be able to get kind of more granular race and ethnicity data, for example, the category of Asian is really difficult to sometimes know what to do with that category because it's so broad, and it would be much more useful to have more granular racial and ethnic identity information for that group. But because we don't have in-depth census data on all of those groups, it kind of limits what we can. So often we find that we will roll up into larger categories for reporting out. So there's a lot of work that could be done. I think, especially with the vaccine data, there is a lot of work to try to make sure that we have really much better race and ethnicity data for the vaccine work. But I think that some of the issues are still present in that data system too.
We have another question asking, is private system data included? Northwell, NYU, Columbia Presbyterian was never included in reported data last spring, only HHS hospital data. Yeah, Corinne?
So the answer is yes. So anybody who lives in New York City who gets diagnosed anywhere will be reported to us. So you may be looking at trace data. I'm not sure. There may be instances on the internet where it's only health and H&H data. But for all the data that we've put out since the beginning, we have all systems, private, public, everything. Yeah.
Thank you. And we also have a question. It was great to have data available on the zip code level because that's probably the most cognizable by most people. Is there a plan to make data available by, for example, NTA? I'm not entirely sure, whether or not there's a plan to do that. I can speak as a data communicator about, some drawbacks to making data available in, several different geographic schemes. I think it means that an agency is sort of speaking out of both sides of its mouth, or offering the possibility that someone looking up neighborhood for their data can find two different answers and not be entirely sure about why. So I think, again, speaking from the perspective of data communication, I think it's best to sort of pick one that is most likely to affect the most people and the most policy, and stick with that. Corinne, do you have any thoughts on making data available by different geographic schemes?
Yeah, there was a lot of, sorry, I'm not on mute, am I? There was a lot of discussion on this, and we know that the city planning folks really like NTA, and we've been trying to move as an agency, or at least as a bureau, toward NTA because we recognize the kind of inherent values of NTAs over zip codes especially. So the reason we chose zip code at the very beginning is more out of a practicality. All of our information will come in with zip code information. So we have positive cases and also negative people who got tested but tested negative. All of that information comes in with a zip code. We have to geocode and to get anything beyond the zip code. And so because our data systems couldn't handle the volume, we bring in positive cases to our kind of main surveillance system where we geocode them, but we don't bring in the people who get tested but test negative. So therefore, we don't have geocoded data available for our negative cases, our negative patients. And so this matters for things like percent positivity, where you need, the total number of people who tested positive divided by the total number of people who got tested by some time and some space. So we recognize that zip codes are not ideal because they don't nest well and they're kind of wonky, but we started with zip codes just as a matter of convenience, and we haven't moved away from it. So we look at NTA level data internally, and I think there was a discussion at one point to put NTA level data on open data. So we'd welcome further discussion if that's of interest.
We also have a really interesting question here. Can you talk a little bit about different health data used to measure COVID impact and what's best for policymakers to use? For example, using death rates versus positivity rates versus other COVID metrics. I think that's a great question. And that gets at some of the things that Corinne mentioned earlier on about kind of epidemiologists offering, a perspective on data that understands how infectious disease works. The answer is, and Corinne, please either back me up or take me down a peg or two on this. The answer is it depends, and I think it's important that any of these metrics doesn't just work for any one thing. It really needs to be considered in context. For example, positivity. If you look at the historical positivity for New York City at about this time last year, or let's say 50 weeks, it spiked to over 70%. 70% of people tested were testing positive, and the reason for that is because the message was, if you are sick, stay home. Get care if you think you're going to die. And so there was limited testing availability and hospitals were filling up. And I'm getting a little bit choked up remembering this. That was the situation on the ground that affected the fact that people being diagnosed reflected the most severe cases because of that condition. Whereas what's happening now, much greater numbers of testing, we are identify cases of varying severity. So understanding the context that these metrics exist in, I think means that there really is, there's no one answer that this metric is best for understanding this. It's that each of these exists in a context. The context is, how are these data being collected? What is the public being told? What are they doing? What's happening in clinics and hospitals across the city? That means that for anyone, what piece of data that may answer it might vary. I know that that's a very loosey-goosey answer, but I hope it's a little bit of a helpful glimpse into that. Corinne, how do you feel about that issue?
Yeah, I would say that we, as Matthew said, it depends. And we use streams. So we have a lot of different streams of information coming in. And when there's a pattern or a signal in more than one stream is when we, as just generally public health surveillance, people start to pay attention. So for COVID, we have the syndromic surveillance, so ED admissions or ED visits for what we call COVID-like illness. So this is people with a fever or cough or shortness of breath. So we get that data feed from all 53 emergency departments. We get that data feed and have a whole team of people who work on that. And that's a very real-time indicator. It's not very sensitive or specific because it could just be a person with a fever doesn't necessarily have COVID, but that's kind of a real-time data source that we have. The more real-time, but still not great, is percent positivity, which after about 3 days, we can start to trust the percent positivity. As was mentioned in the question, we also have hospitalization and death, but because of the lags on those data streams, it can take a while for deaths to be reported to us, especially. It's a very reliable signal, but it often takes too long for us to be able to do anything. So what we'll typically do is we have our fingers in a lot of different data streams, and when we start to sense in more than one, that's when we start to pay attention. And I'll also say that it'll probably change over time. So as we move forward with COVID, what we're hoping is we kind of enter an influenza-esque sort of situation where we are going to be relying primarily on syndromic surveillance from emergency departments because we think that that's probably going to be the most robust way to keep a handle on this pandemic. Percent positivity we have used, but because of increasing in testing for screening, for people who are going back to work and get tested once a week, for example, that kind of makes the utility of the metric for tracking COVID across the city less useful. So I don't know this, but I think that we may, as a field, move away from percent positivity over the next couple of months to a year, just because it will become less useful as a way of tracking transmission. So it changes.
There's also a question a little bit earlier on. Questions that the public asked changed over the past year. Were you able to change the information included in the data files? By and large, the answer is yes. We were able to add more and more data throughout the year, add more and more visualizations to the website, reconfigure the website so that when people were landing on it, they were getting what we felt was the most relevant information for right now. I think the biggest example of this is we started out reporting cumulative data, right? We were reporting daily case counts and hospitalization counts and death counts, but then we were also reporting case rates, death rates, and percent positivity by zip code. After a certain number of months, that cumulative look was less useful to understand what was happening right now, right? As that initial wave subsided, we needed to look at what's happening right now. And so we started to experiment with a few different ways to bring a very recent focus on it. So we were doing one thing with weekly rates for a little while, and then in the fall, through press conferences with the mayor, there became a real focus on looking at this 7-day average percent positivity. So we started releasing those same data in order to make sure that people could follow the data that policymakers were using to make really important decisions. We're getting a lot of questions in here. There was one, let me take a look here. Would you be able to provide a more in-depth description of the information you were able to gather directly from medical reports versus data gathered from other sources? And a second question of the statistics you've been able to provide, which has been the most difficult to present accurately? Corinne, you look like you have thoughts.
I don't know the answer to that second question. The first question, so the answer is that we get data from a ton of different sources. The basic rule of thumb is that if you're a case but not hospitalized, we probably don't have a great deal of information on you. But the more severe you are, the more information we'll have about you. So if you've been hospitalized, there are a couple different ways that we'll be able to access that information. And unfortunately, if you pass away, the death certificate and our Bureau of Vital Statistics will be able to get a lot more information off of people who pass away. Obviously, that data will be lagged, but we tend to have more information on the more severe cases. So there's just a number of different, sometimes we'll get information directly from a hospital system. Sometimes we get information imported from what are called regional health information organizations, which are kind of collective groups of hospital systems. But all of this was kind of new and set up for COVID. Typically, we don't do this in real time. We started at the very beginning investigating every case, but that very, very quickly became impossible within the first 2 weeks. Actually, about this point last year, we stopped doing that because it just was overwhelming. So we've kind of been changing our surveillance system in real time in response to the volume and our resources. And in terms of that second question, I don't know. What's been the most difficult thing?
maybe the antibody testing data, which were we the first jurisdiction to report the results of, no, not the first jurisdiction. We're early-ish maybe to report the results of antibody testing data, which was really interesting, but sort of difficult to figure out exactly what we were learning because the people who were going to get antibody tested was not a representative sample. So varying positivity or test rates were interesting, but we didn't necessarily know about what.
I think the most difficult thing has been explaining how our numbers differ than the states.
Yeah, that's a really good point.
Over and over and over again.
And one of the big ways that's been an issue is with percent positivity. The state calculates percent positivity differently. So our numbers, they sort of follow each other, they parallel each other, but they're different numbers. And that is frustrating to people. And it's sometimes, really difficult to say exactly why.
More than one truth. Yeah.
Yes. Luis asks, what are key learnings on collecting and reporting data to the public and decision makers that could be applied outside of a COVID or outbreak scenario? And this, I'm going to be happy to get up on a soapbox and say that I think it's vital to explain data, to communicate it clearly, to do so with an eye toward the right digital tools for the job, good design, plain language. I think that data are really useful to a limited subset of people and can be interesting and available and helpful to so many more people. I think that bringing a health communications lens, a plain language lens, and a sort of data viz cognition lens to this work can be so valuable in a public health context and just in a public context. We work with public data. This information is not ours. It belongs to you. It belongs to us. It belongs to everybody. I believe that everybody should have access to it. Physical access, right? In terms of digital accessibility and like understandability access. I don't want to provide data only for experts. I want to provide data for everybody. We are getting very close to 2 p.m. and I want to keep an eye on the time and let people get on to the rest of their day or their next Open Data Week talk. There's another question here that I do want to answer quickly. Did anyone look at testing from the perspective of some people may be tested regularly, others are first timers? The answer is yes, actually. If you dive into the GitHub repository and look into files on testing, you'll see that there are often comments and documentation around deduplication. And that's one of those issues that comes up when people sort of take some of our files and they try and make their own calculations and then they go back to other data in our files and it doesn't really match up. But often, deduping data to look at unique people tested over the period of time that we're looking at is something that happens and affects the values that we look at. And I think a final question that we can field here is, you mentioned in the beginning that government agencies are normally slow, but now you've sped up releasing data. Do you think you'll keep these practices even as COVID dies down, or will you fall back on how often you're releasing data? I think that the practices that are really most important to keep are the sort of open access and explanation practices. I don't think it's important to update data on everything every day, personally. That sort of level of granularity is not always helpful. It's been absolutely vital for COVID. The school that someone's kids go to might be shut down based on how the data changed from yesterday to today. Businesses might be shut down or open based on that. That really affects what happens in day-to-day life in the city. But that's not the case for a lot of things. So I think that there are some other things. There's some parts of this that we want to absolutely keep as part of the culture, and some things that won't be necessary in other contexts. With that, I think I'm going to stop our screen share here. I've got an eye on the time. It's 2 p.m. We're so grateful that you all could join us. We are grateful that you asked a lot of questions. I guess given the questions that came in, we're also grateful that we sped through some of the material that we really wanted to share with you all so that we could have this conversation because I think it's really interesting. And it's great, going back to that issue of support as user research, it's always great to hear what other people are thinking about and responding to with this data program that we have, so that we can think about how to continue making these data available as a public service.
Thanks, everybody.
Yeah, thanks so much. Enjoy the rest of your Open Data Week. Attend many other talks. And did I hear some audio coming in? Nope.
Thank you all.
All right. Thanks so much. Take care.
Bye.